Now let's go to part 2 of the Priester splint. And the Maryland bridge morphed into the Rochette splint. And you will notice that it had multiple perforations, and this was more retentive than the Maryland bridge because it allowed for these multiple openings for bonding material to squeeze through before curing. And the bonding material was used rather than cement, and this is the original article by Dr. Rochette. The main cause of Rochette splint failure is the fact that the erosion of the material in the openings, and this was published in 2001. From attempting to repair a Rochette splint came the idea of the Priester splint. Here we see which was a complete Rochette splint, and on the central and on the canine it came the tooth separated from the splint. So what Dr. Priester did, he went in and cut the metal out, created a broad area that you noted here, put a bevel, an external bevel on this that we will discuss, and rebonded it, and it ended up being in place for many years, as you will see. Let's look at the long-term results on this case on this 30-year-old female in 1975, and you can see the amount of bone loss. You can imagine how mobile these teeth were. And then we see her in 2009, many years later, and we can see on the central incisor where the Priester splint was first prepared by removing the holes and creating a broader area, especially with an outward bevel on that, which we will emphasize over and over and over. The Priester splint, it's an open face rather than a solid plate. Number 2, the outward bevel is the key to retention. Let me repeat that. The outward bevel is the key to retention. It's an alternative to mandibular implants or a fixed bridge and a removable partial denture. And in this economic environment, there are many patients that cannot afford implants, and especially older patients, and this offers a wonderful alternative. It's very aesthetic, it's easy to repair, and we will discuss that later. And in the event that a tooth becomes periapically involved, performing endodontics on that tooth is quite simple. Let's go over some of the specifics on this, which are so critical for this splint to remain in place and not come loose. First of all, there is a definite finish line that you can see on these black arrows. So the bonding material is not only on the tooth, but it flows over that bevel. So the red represents the bonded material that is over the bevel. You would like for the bevel to be 2 millimeters ideally in length, and the area between the finish line and the bevel should be very roughened and unpolished, and beyond the finish line, that part of the splint is highly polished. The mistake. In this particular case, this looks nice. However, there was no bevel placed on this, and this splint came loose in about 2 years. So this is that same case, and we can see, as we see here, a vertical defect, and down here you can see how the vertical defect is filled in, and look at how much difference the bone is, because in 2013 these teeth were probably 2+ to 3 mobility, and the fact that they're stabilized now and we have got crestal density, which is a very key point. So this is that patient. We saw it earlier in the first video where a zirconia bridge was done to replace number 7, and we can see the periodontal health there we're talking about. Let's go back now to the original case that Dr. Priester did in 1975 on this case, and you will see the aesthetics, the good plaque control, and so forth, and this is some 30 years later. This is the lower area. But notice when the patient smiles how aesthetic this is, and the lower teeth really do not show. But notice the crestal density. This is 30 years later. There is no active periodontal disease. There is no bleeding on probing. And I submit to you that this is a periodontal defect and not a pocket. Now let's see how easy this can be learned or taught. This was a case that was sent to me by a gentleman from Morocco who was with a French group when I was lecturing in New York, and he did this case simply from my lecture. Here's the lingual view, and here is the Priester splint in place, and the mistake is you will notice that the bevel on this is highly polished. That means it will not be as retentive on the bevel, and so that should be roughened as you noted on the original splint that we showed you earlier. The anterior view, certainly he used a rubber dam on this because we do not want to contaminate the bonding material with saliva. And note that there is a finish line on this, as we see here. And the bonding material comes over the finish line just like it was in the original case. But now let's compare it to the original case. Look how much more bonding area is on the original case versus the gentleman from Morocco. And the reason for that is if you measure from here to here, transpose that to the other side, look how much further the splint could have come incisally, and the area bonded in the middle would be much greater, that the bevel would be greater, and it would even be more retentive. But in any event, this is the splint in place, and we do not show those embrasure spaces when we smile, and we do have periodontal health and a very aesthetic result given that the lip does not come down this far. Another case, you will see that we have bone loss almost to the apex. Certainly, if this tooth becomes periapically involved, let me show you a trick where you do not have to do endodontics on that. You simply lay a mini flap on the facial and do a slight apicoectomy so that this will heal above the tissue and no root canal would be necessary. But to make that even more retentive, you will notice that there is a pin, a self-threading pin placed in this so that that will make it stronger. And this is a 42-year-old post-op, and you will notice the lateral incisor to your right has been amputated, and notice the periodontal health and certainly a reasonable, very aesthetic, very inexpensive result that has held up for many, many years. Now let's ask some questions. Does this technique meet the objectives of periodontal splinting? First of all, it stabilizes teeth and prevents migration of teeth. Second, it permits the patient to perform effective oral hygiene. It's non-irritating to any soft tissues, the lips, the cheek, or the tongue. Requires only a minimal amount of tooth surface reduction even if you reduce tooth structure at all. It distributes occlusal forces over as many teeth as possible. It is aesthetically acceptable. The technique is simple to perform and more affordable to the patient, as we've mentioned. So therefore, consider this as an alternative, using critical thinking perhaps to render a simpler technique, especially in our older patients.